Okay. Now, we had presented the topic on immunization, special circumstances. We had discussed many things like immunization in bone marrow transplant, before bone marrow transplant, what you should do, after that, what you should do, immunosuppress when you give medicines, steroids, etc. Therefore, these are very important points. We have also discussed maternal immunization and is blunting on the newborn immunization, etc., which will come up for the MCQs later. Now, there are a few more. We finished 39 out of 64 slides of immunocompromised children. The rest of it we will continue. Today, we will discuss, start with solid organ transplant. That is a patient who's going in for renal transplant, which is not uncommon today. And in your practice, this will become more and more common. And more, other consultants will start asking you questions about it, may take your opinion. Can you read it, Ashwati, from the beginning? Solid organ transplant.
Solid organ transplants. The need for immunization in solid organ transplant recipients can arise
Please,
from
loudly, please. Yeah.
The need for immunization in solid organ transplant recipients can arise from three factors, each causing suppression of the immune system. The immunosuppressive activity of the underlying disease, example, the chronic renal failure, rejection of the organ graft, and the immunosuppressive therapy given after transplantation. Immunization can be given to candidates awaiting transplantation because the immune response then is less likely to be significantly suppressed and the patient is more likely to respond to the vaccine. Many of the conditions for which the patients undergo organ transplantation are at least to some extent immunosuppressive, and vaccination should be considered early during the disease. Solid organ recipients generally receive lifelong immunosuppression. The degree of immune suppression is greatest in the first 3 to 6 months post-transplant.
So this is a problem because these patients are going to give lifelong immunosuppression. Therefore, any vaccine you give may not be that effective. That is understandable. But pre-transplant, you have to make sure that the immunization is well up to date. At least the killed vaccine are given at least 14 days ahead before the immunosuppressive treatment is given, before organ transplantation is done. That's one thing. Okay. But anyway, they are at risk even after you give immunization because they are on lifelong immunosuppression. Okay. Carry on. Can you see?
Yes, sir. Generally, standard vaccine series should be given to children awaiting solid organ transplant. Recipients of solid organ transplant should complete all age-appropriate immunization prior to transplant in accelerated schedule if needed. HPV vaccine should be given using a 3-dose schedule regardless of age. Transplant candidates should receive PCV regardless of age, PPSV if 2 years of age or older, and 1 dose of Hib vaccine after age 5 years regardless of prior Hib vaccination history. Quadrivalent conjugate meningococcal vaccine is recommended if there are risk factors for meningococcal infection, example hyposplenia, complement deficiency, or increased risk of exposure from the travel or occupation.
Okay, this is meningococcal vaccine specifically indicated, after bone marrow transplant is indicated definitely because all the memory cells are given. What you should note here is the transplant should receive PCV regardless of age. Normally, PCV is given up to what age? Catch-up immunization in immunocompetent children.
5 years.
Hello, how much?
15 years. 5 years.
Suppose a child 7 years old or 8 years old comes. He has not taken immunization. Will you give pneumococcal vaccine? No, it is given only.
He's immunocompromised.
No, I'm asking immunocompetent child. The normal child has come. He has not
5
taken.
years, sir.
He has nothing problem. Only thing he didn't take immunization. This will become more and more common as it in the Western world is becoming more common. In India, Kerala also has vaccination lobby becomes more severe, you will find children of educated people not getting. Suddenly at 8 years, they may come and say, okay, let me vaccinate. Will you give the pneumococcal vaccine? No, after 5 years, pneumococcal vaccine is not given. Hib is not given. But when you have a transplant patient, you should receive the PCV regardless of age. That means he should receive 0, 6 weeks, and 6 months. And Hib, he should receive only one dose. That's what you should understand. Recipients should complete the age-appropriate immunization prior to transplantation in accelerated schedule. What do you mean by accelerated schedule? What do you mean by accelerated schedule? If I ask you, Gopika, can you tell me what is accelerated schedule? Amal, can you tell me? You have appeared after a long time. Rose, can you help? Hello? Amal disappeared after. See, please.
Immunocompromised child, more frequent, the duration between two vaccines can be shorter.
Yeah, you see, especially the first, if you are giving 3 doses, the best schedule is 0, 6 weeks, 6 months. Now, the problem arises, you might give after 1 month also the second dose. That's the shortest you can give. In certain vaccines, like the certain the diseases like chickenpox, you might give after 3 months because you don't want chickenpox to come. That's called an accelerated schedule, which you give. And pentavalent vaccine, etc., they say was 0, 1, 2, and then 6 months. Therefore, there is an accelerated because you want to protect the patient very fast. You don't want to lose him after a solid organ transplant also. But remember, accelerated schedules may not be in the long term. It may not be that effective as a correct, the scientifically correct schedules. Rose and others, when you answer, please unmute your mic when I ask you questions, if at all. Okay. Read it now. Pre-organs. Can you read?
Pre-solid organ transplantation. Vaccination schedules with inactivated vaccine should be completed at least 2 weeks before the scheduled transplant. Vaccination with live vaccine should be completed at least 4 weeks prior to transplant. MMR and varicella vaccine may be given to infants 9 to 11 months of age if transplantation is expected to occur before 12 months. If transplantation is delayed, repeat dose should be given starting at 1 year of age. It is desirable that seroconversion be documented.
MMR varicella vaccine can be given 6 to 11 months, not 9 to 11 months. Remember, during an epidemic, we give the measles vaccine at 6 months. Normally, it is given not before 9 months. During an epidemic, normally hepatitis A is given after 1 year. I think after 15 or 16 months. It can be given at 12 months. These are this which you occur. But when you give before the time, you should repeat the vaccine. Okay, go
The
ahead.
optimal time to begin vaccine administration after transplantation is not defined. Immunosuppressive therapy is often most intense during the first couple of months and might influence the effect of vaccination. Inactivated vaccines are safe in the post transplant period, however, they are best administered at least 6 months post transplant to elicit the optimal immune response. In patients where the immunization has not been completed prior to transplant, vaccination with inactivated vaccines can recommend 6 months post transplant when immunosuppression has been lowered. Boosters for inactivated vaccine should be given as per schedule or when the antibody levels wane, hepatitis A and B, starting 6 months post transplant. Annual influenza vaccination is recommended. All household and the healthcare workers contact should be immunized against influenza, measles, rotavirus, and varicella.
One more line has come, I think. Before that, I would say that you normally give the vaccine after 6 months. Now, the question here is, if the patient has been fully immunized before this one, before solid organ transplant, he's completely immunized. Do you have to repeat the vaccination post-transplant? It is not like a bone marrow transplant. It's a hematological, what you call bone marrow transplant, where the memory cells are gone. In patients who completed prior to vaccine inactivate, therefore that means those who have completed the vaccine may not require the vaccine booster. Maybe only booster doses. Therefore, booster doses are given only for inactive vaccine, should be given as per schedule when antibody levels wane. The vaccine which is required is annual influenza vaccination. Okay, up to 9 years, I think 2 doses in the first year, and later on every year you should give. That's a vaccine which is given. Uh, Generally, last sentence you read.
Generally, all live vaccines are contraindicated in the post transplant period. However, recent studies show that live vaccines may be administered at least 1 year after transplant and when the degree of immunosuppression is very low.
Okay. Therefore, post-transplant, remember there's a difference in the immunization of a solid organ transplant and a bone marrow transplant. In bone marrow transplant, you have to give the full immunization after 6 months, including DPT, including meningococcal vaccine, including pneumococcal vaccine. Because the complete memory is like a, but I think in solid organ transplant, the dose is after 6 months for killed vaccine, and live vaccine, it is after 1 year. It might be worth looking at the antibody level before you give the immunization. These patients require protection against varicella, measles, everything. And then that is very, very important in these patients. Now, let me tell you, recently I saw a WhatsApp program in which a famous actor, Prem Nazir, his son was talking about his death. He was telling us that he had some problem. He was given some immunosuppression. He was very much immunosuppressed at that time. Thousands of visitors gave to see him. Somebody gave him measles and he died of measles. You remember that? Therefore, when you are immunosuppressed, if you get measles, you can die of it. You can die of chickenpox. But remember, it's very important. See how it will happen to you. If a patient has been given a renal transplant, miraculously saved from renal failure, and he subsequently dies of a disease like varicella and chickenpox, varicella or measles. Therefore, immunization becomes very important. You should, when you decide on it, open the latest book of immunization, whatever the IAP has, or the clearly go into it, and then or the CDC, and then decide what to. Right now, if you are asked, live immunization after 1 year, check the antibody level. Antibody level is low, definitely give him. Routinely may or may not be react. The routine vaccination, which he definitely requires, is inactivated influenza vaccine every year. And dead vaccine, inactive vaccine, you begin at 6 months. Live vaccine, you begin at 1 year. Now comes to a very important problem, asplenia or hyposplenia. Now, one of the commonest reasons why do we see hyposplenia, why your examiners would come to you is patients with which condition? Uh, Amal, you go for practical, they can ask you that question. Amal is there? No, I don't see. Ashwati, can you answer? See, when I ask a question, unmute and answer, please. Gopika, you can answer. Unmute and ask.
Sickle cell disease.
Yeah, sickle cell anemia is supposed by 2 years to produce what you call asplenia. That is why normally when you get an exam, I am talking to Amal. How do you diagnose a hemolytic anemia? Amal, you are going to go for practical. Amal, are you hearing me? Unmute and talk, Amal.
Yes, sir.
Yeah. How do you diagnose hemolytic anemia?
Child is paler with icterus.
That's what they will tell you in theory. Okay. In practice, the commonest hemolytic anemia you will see it when you go out of Kerala. Where are you appearing for your practical?
Chennai, sir.
Okay. There will be thalassemia. Read very well about tuberculosis. Read very well about hemolytic anemias. Okay. Management. Hemolytic anemias, I am not too sure. Tuberculosis, you read very well and go. Most of the case will be tuberculosis there. Then hydatitis, etc. Now, hemolytic anemia, anemia with splenomegaly. But in many patients, the anemia may not be very evident. Him, bilirubin jaundice will appear when the bilirubin when the hemolysis is rapid. You may get in newborn. You may get a very mild icterus in the hemolytic anemias which you see. Therefore, it is difficult to make out. Therefore, any patient with unexplained splenomegaly, one of the diagnoses in other countries is when you go out of Kerala is either if it is fever, it is malaria. Fever, it may be typhoid. If it is anemia or unexplained, it is likely to be a hemolytic anemia. And the most likely to be is what they call thalassemias. Sickle cell, will you get a hepatosplenomegaly? Normally, no. By 2 years, because of the sickling effect, there is splenectomy. Therefore, these patients become hyposplenism by the age. Therefore, you may not get a spleen. But it's normally said that if you get a spleen about 2 years, it's unlikely to be sickle cell anemia. But if the patient has got iron deficiency anemia, hypochromic microcytic anemia, sometimes the spleen may still be palpable. Now, anyway, now read out what is given about asplenia or hyposplenia regarding immunization.
Asplenia or hyposplenia. Asplenia or hyposplenia may result from sickle cell disease or radiation therapy involving the spleen. Children with asplenia or hyposplenia are at high risk of serious infections with encapsulated organisms. Vaccination with a pneumococcal, both conjugate and polysaccharide, hep conjugate vaccine, meningococcal conjugate vaccine, and typhoid conjugate vaccines is indicated in addition to all routine vaccines. In patients with planned splenectomy, vaccination schedules should be completed at least 2 weeks prior to splenectomy for achieving a superior immunologic response. In those who have undergone emergency splenectomy, studies indicate that vaccination done 2 weeks after splenectomy is associated with a superior functional antibody response as compared to vaccination immediately following surgery. However, vaccination can be initiated at the time of discharge. All live vaccines may be safely given.
Okay, therefore all live vaccines can be safely given. That's therefore these are very important points because what many times splenectomy is done during previously whenever there is splenic rupture in a patient with a trauma, a splenectomy is done. Nowadays, people try to what you call retain the spleen, even in patient hypersplenism or even in congenital spherocytosis. Splenectomy is not done like previously. One of the hemolytic conditions in which splenectomy is done with curative is congenital spherocytosis. But even there, they try to keep apart because of the risk of infections. People try to preserve the spleen to a certain extent. In thalassemia, is splenectomy done, Amal?
No, sir.
Done or not done? Please read it very carefully, Amal, before you go for practical.
Not done, sir.
Not done. Gobika, what do you say? Gobika is there.
Yes, sir.
What
Not
do you?
done, sir.
Not done. Never done. Ashwati, only four of you or three of you are there. Huh? Anybody else? Okay. Paris joined and he left, I think. Okay. Ashwati, can you
Sir,
tell?
ഉണ്ട് sir.
Paris ഉണ്ട് ഒളിഞ്ഞിരിക്കുക. Okay. Paris, can you tell when is splenectomy done in thalassemia? Amal will be asked this question. Thalassemia splenectomy is not done early, but when hypersplenism becomes common, that means the transfusion is less than 1 in 15 days, you may do splenectomy. But we will prevent splenectomy as I am diverting from this to help Amal in the exam. Now, when you do blood transfusion more frequent than every 15 days, you suspect hypersplenism. Sorry. then you do a splenectomy. The problem with why we don't do splenectomy is the iron will, instead of getting stored in the spleen, will go and get stored in the liver, and the patient will go into cirrhosis faster. Therefore, we will postpone the splenectomy as much as possible. Okay, that is it. Now, see here, this is from Nelson's test book of pediatrics. And I just want to say that there's pneumococcal vaccine, that is pneumococcal polysaccharide vaccine should be given after 2 years. MCV and meningococcal beginning at 10 years. Meningococcal B, I don't think is available here. If it not administered in infancy, if it is administered, you need not give asplenia. Now here, remember, you give only after 2 years, after 8 weeks after the conjugate vaccine. Last conjugate vaccine, 8 weeks after that, you can. All routine vaccines are probably effective. That is what they say. Now children with chronic diseases. Okay, can you read it?
Chronic diseases. Children with chronic neurologic, endocrinologic, diabetes, liver, renal, hematologic, cardiac, pulmonary, and gastrointestinal disease are at increased risk of infections and serious infections. Live vaccines may be given safely in these children. These children should be offered pneumococcal, hepatitis A, varicella, influenza, and rotavirus vaccines. The immunogenicity, efficacy, and the duration of protection of vaccines are lower than healthy children and hence indicated higher antigen content or more doses like hepatitis B. Assessment for antibody response and the frequent boosters like hepatitis A or B are recommended. It is important to stress the role hepatitis A vaccine in patients with liver disease and pertussis booster in those with stable neurologic disease. Children with cystic fibrosis or celiac disease may mount a suboptimal immune response. Hence, assessment of antibody response is recommended. Children with severe cardiac and pulmonary diseases should receive pneumococcal and annual influenza vaccines.
For all these patients with congenital cyanotic heart disease with significant, who should receive annual vaccine. Hepatitis B, a double dose should be given, they are telling. I don't know whether it's followed here. For chronic diseases, yes, I don't know how much of, we don't see that much chronic diseases in children, except neurological disorders. But whenever you see it, make sure that the vaccination is complete, as is given in this book. Now the question is, what happens when you have a patient with a history of allergy? Now, it is not completely discussed here. I have put up two. I will share with you my presentation on anaphylaxis, which I considered very, very important. How to diagnose anaphylaxis and what is the significance in our practice. Very, very important. Anyway, let me read out your whole thing now.
Immunization in children with history of allergy. First time immunization with any vaccine is contraindicated in children with history of serious hypersensitivity or anaphylaxis to any of the vaccine components. The package label should always be checked for vaccine constituents, which in addition to antigen includes stabilizers or buffers, preservatives, antibiotics, and residue from the manufacturing process. All vaccinating units need to have adrenaline, antihistamine, parenteral steroids, and oxygen available at the site of vaccination. Children with history of serious egg allergy should not receive yellow fever vaccine but can safely receive other vaccines including measles and MMR vaccines. Children with history of egg allergy who have experienced only hives after exposure to egg should receive any influenza vaccine, inactivated, recombinant, or live attenuated, without specific precautions except a 15-minute observation period. Children with previous anaphylaxis to egg can receive the
Inactivated influenza vaccine.
inactivated influenza vaccine in a center where the staff experienced in recognizing and treating anaphylactic reactions are available, and the child should be under observation for a minimum of 1 hour.
Okay, doctor, now I'll tell you one thing. I have put up two videos which I think are very, very good on the YouTube on anaphylaxis. I would expect you to read it, see it, but I will not be discussing anaphylaxis. I will be straight away putting the MCQ on it because we are losing time. Therefore, that I don't think you can, or as all pediatricians, please, wherever you give. Now, Dr. Amal and Dr. Faris are going for primary health center. Make sure that they have adrenaline, at least 2 ampules, which are not expired date. Make sure that they have hydrocortisone. If it is not available, don't give. The problem that arises is they won't have it. And they will say, we are giving it for so many years. The best thing is adrenaline is less costly. Buy then keep it with you. Whenever you are there and the patient is getting, let adrenaline be available with you. It's a life-saving medicine. No other medicine is effective. The diagnosis of anaphylaxis, if you are not given adrenaline, you have not treated it. Please understand that. And it's a huge medical legal issue. And how to diagnose anaphylaxis, what are the pitfalls in diagnosing, I discussed. I don't want to waste. Number two, what you should note here is egg allergy a contraindication or to give a measles or measles vaccine? No, it is not. Especially rashes, no. The only history of serious egg allergy, like anaphylaxis, is a contraindication to give yellow fever. If you take egg and the child develops rashes, even then you can give measles vaccine. Now they have said that specific precautions here in 15 minutes. Remember, wherever you are giving vaccines, don't do the way the PRS hospital is doing. Though I have told consultants 100 times, they don't agree. Give the vaccine, make them stay for at least half an hour. In fact, they say 45 minutes. Ask them to come back, see, write the vitals are stable, then only send the patient. You can get an anaphylaxis in minutes, in hours. In fact, you can get it in the first, even after 6 hours. But you can't make the patient wait 6 hours. Minimum wait 15 minutes. They say better to make them wait for 45 minutes. See the patient again and then only send. Anaphylaxis is a huge problem. The other problem of allergy is the moment you diagnose anaphylaxis in a child who has been given an hexasim or a hexavalent vaccine, what vaccine can you give next time? You don't know which vaccine produced the allergy. Therefore, you are in a conundrum. You can't immunize the child patient. Therefore, you cannot but diagnose anaphylaxis when there is hypotension and a severe problem. But once you diagnose, the child is in trouble for further immunization. Therefore, that's the point we will have to discuss. We will discuss it in a later time. And let me tell you, it is not children with allergy alone. All children should, what you call, receive yeah, this only if it is not only patients with allergy, every patient should be kept at least for 15 minutes. Okay, now read it now.
Children who have had a serious hypersensitivity reaction or anaphylaxis to a particular vaccine must never receive it again. A mild reaction is not a contraindication to vaccination. In any case, all children should be watched for at least 15 minutes after vaccination for allergy, and the resuscitation equipment should be kept standby. Children sensitized to a vaccine or its components with previous anaphylaxis to this vaccine should be revaccinated only if absolutely necessary, like rabies vaccine. In this situation, rapid desensitization with increasing vaccine doses is administered every 15 to 30 minutes, provided that there are no signs of allergic reaction. 0.05 ml of 1 is to 10 dilution, then 0.05 ml, 0.1 ml, 0.15 ml, 0.2 ml of a 0.5 ml full strength vaccine. This results in transient desensitization, and such children must still be considered allergic to the vaccine. This protocol should be done in a setting where prompt treatment of the anaphylaxis by experienced staff is available.
Okay, these points are very important. Remember, the one thing which they kept out is when you give a hexavalent vaccine, if you pronounce him anaphylactic to that, you can't give any of the vaccines. It's a major problem. And previous anaphylaxis, revaccinate. Rabies, of course, you will vaccinate. How to do the desensitization is not given very much anywhere. Therefore, this protocol, you may not be able to remember it by heart. Whenever you have to do it, oh, remember that's given in your purple book. Ashwati, have you bought the book, which I said? The latest immunization IAP book? Or
No,
do you
sir.
have a PDF of it?
Yes, sir.
Rose, you have it?
Yes, sir. Yes, sir.
Okay. Keep it with you. The latest book, always keep it with you, because these are issues of very important from the medical legal angle of view. Let me tell you, even in PRS hospital, when I joined 2018, I first thing 2017, 18 April, the first day I went to the immunization clinic and I asked them, please, is the emergency medicine available? The nurse, they said, yes, sir. And then I am the person who put up that chart there, put up wherever you are working, put up the chart, what to do when you have an anaphylaxis. And number two, I asked them for adrenaline. They looked at each other and said, sir, it's available. I said, I want to see with my eyes. It was not there. It had about a month ago, it had gone because the date of expiry had gone. They were giving injections without adrenaline. And they were telling that the ward is nearby, therefore we can take it anytime. Do not accept any one of these things. Here, please remember what he has written in this book. Resuscitation equipment should be kept standby. Now, if you are giving somewhere you don't have the resuscitation equipment, they can ask you, why did you give it without that? So these are all medical legal issues. So wherever you, I'm sure none of the primary health centers will have a resuscitation equipment next to the immunization clinic. It should be there more than in the year. But remember that at least one is available for you, but for your own sake. Okay. Now the next question, can you read the next one? Lactation. Can you read it? Hello, Ashwati, is it changed?
Yes.
I read it.
All inactivated vaccination in lactation. All inactivated vaccines, whether conjugated, toxoid, or subunit vaccines, are safe in breastfeeding women and pose no harm to the babies. Although live vaccines multiply in the body of mother, most pose no harm to the babies as they are generally not excreted in the breast milk. Rubella vaccines may be excreted in milk but doesn't infect the baby or if at all cause asymptomatic infection.
The only vaccine, live vaccine, which is contraindicated in lactation is, yeah, read it.
The only exception to live vaccine use is the yellow fever vaccine. Transmission of the yellow fever vaccine virus through the breast milk and resulting in infantile meningoencephalitis has been described. Hence, the yellow fever vaccine should be avoided in breastfeeding mothers. If mandatory, then breastfeeding should be interrupted for the 10-day post-vaccination viremic period.
Okay, this is yellow fever. People may not come to you. I think yellow fever vaccine is not available in private. Therefore, your vaccine may not be given, but still you should know yellow fever vaccine, egg allergy contraindication, yellow fever vaccine. Patients on what you call breastfeeding, you should avoid yellow fever vaccine for at least 10 days. Still, as a pediatrician, you should, uh, okay. Now we come
Immunization.
to, yeah, but this is a very important point. We are coming to the immunization in preterm and low birth weight babies. And this is a very important point. Okay, carry on.
Immunization in preterm or low birth weight infants. In principle, all vaccines may be administered as per schedule according to chronological age, irrespective of birth weight or the period of gestation. BCG and the birth dose of OPV can be safely and effectively given to a low birth weight and preterm babies after stabilization and preferably at the time of discharge. Studies have shown that the take of BCG, as assessed by the induration following the Mandos test and the lymphocyte migration inhibition test, is similar in preterm or low birth weight babies, whether given at discharge or later. The birth dose of hepatitis B vaccine can be administered at any time after birth in babies weighing 2 kg. However, in babies less than 2 kg, the immunogenicity of the birth dose of the vaccine has been shown to be suboptimal in some studies. Hence, the birth dose of hepatitis B vaccine in these babies should be delayed until the age of 1 month. Alternatively, these babies may also be given the first dose of vaccine at the time of discharge if consistent weight gain is achieved.
Regarding hepatitis B, we will come into it in more detail later on. Remember that chronological age is the age at which you should give and not at the time of discharge. Remember that. But there is some confusion even here. Therefore, they say that BCG and birth dose OPV, of course, can be given. Now, that is previously, they don't give rotavirus inside even if it becomes the child is there in 6 weeks of age. Rotavirus vaccine is generally not given because it spreads in the stool, according to them. Previously, the European Union also used to say OPV cannot be given in the in SCABU because it might spread from one child to the other. But nowadays, they are not concerned about it because they don't give OPV at all, especially Americans. Now, we will come into it a little later. It's not easy. We have to. Okay, can you read it? Yeah.
Preterm infants and low birth weight infants with birth weight less than 2 kg have a decreased response to hepatitis B vaccines administered before the age of 1 month. However, by the chronological age of 1 month, preterm babies, irrespective of their initial birth weight in the gestational age, are likely to respond as adequately as full term infants.
Okay. Therefore, even if the baby is less than 2 kg, by the chronological age of 1 month, irrespective of the initial birth weight and gestational age, likely to respond to the birth. Now, there is some problem regarding hepatitis B and BCG vaccination. Now, can you, this is the hepatitis B vaccine as is given in the purple book of, it is given in, see what I am trying to tell you is crucial matters. Sometimes even this immunization books, two things at two times. This is given in hepatitis B vaccine in page 150 of the purple book. What does it say? What happens when the mother is hepatitis B positive? This is hepatitis B immunization and management of preterm infants less than 2 kg. Okay, hepatitis B vaccine. Let me ask you now, Amal, you are going out after two postings in Kabul. Below 2 kg, when are the other children immunized? Amal is there? I can't see him.
Sir.
Yeah. Can you tell me when are they immunized? For heaven's sake, don't. This is how you can go to the level of failing if you don't answer a question. They're not asking you what is there given in the book. They're not asking you what is given in Nelson. They are just asking you in your hospital, a child is 1.5 kg and the mother is known to be hepatitis B negative. When will you vaccinate her? Mother's hepatitis B status positive, unknown, negative. What do you say about it? Is there in front of you? How do we vaccinate here? Gobika, how do we vaccinate in our place?
Uh, if mother is hepatitis B negative,
Yeah,
then uh, at birth itself,
at birth itself. The baby is 1.5 kg. Okay. Rose, when do you give it there? Rose, are you there? I think she's not there. Okay. Uh, Now we'll go ahead and read it. I'll tell you what the problem is. Now, I think everything is important. First, see, it depends on the maternal status. The child is less than 2 kg. I will have to go slow here, I think, because This is very important and practical. The mother is hepatitis B positive. Read throughout. Read all the full lines. Can Gopika read it?
Yes, sir.
Yeah.
Hepatitis B immunization management of preterm infants weighing less than 2 kg. If mother's status is positive, then administer. Um, should I read a whole
Whole
sentence?
thing you had to read because you don't seem to know anything. Okay, read it. Yeah.
Administer HBIG plus single antigen hepatitis B vaccine within 12 hours of birth. Do not count the birth dose as part of the vaccine series. Administer 3 additional hepatitis B vaccine doses at 6, 10, and 14 weeks. Test for HBsAg and antibody to HBsAg 1 to 2 months after completion of more than 3 doses of a licensed hepatitis B vaccine series. That is at age 9 to 18 months, generally at the next well child visit. Testing should not be performed before the age of 9 months, nor within 4 weeks of the most recent vaccine dose.
Remember
If
one
the
thing, stop there here. See, this is what the purple book does. Normally itself, we give 0 dose, 6, 10, and 14. Am I right? This is a normal immunization schedule in our patients. We give 4 doses. 3 pentavalent vaccine contains, I think, hepatitis B. Therefore, 6, 10, and but what do they mean by telling 3 additional dose hepatitis B? I don't understand. Therefore, 0 dose. They say don't count the birth dose. Even if you count it, we will give 6, 10, and 14 weeks. That's one problem. This is the basic of immunization of even a term baby. If the mother is positive, you will test for hepatitis B antibody at the age of 9 months and then decide on further course. Okay. If the mother is unknown status, what will you do?
If the maternal status is unknown, administer HBIG plus single antigen hepatitis B vaccine within 12 hours of birth. Test mother for HBsAg. Do not count the birth dose as part of the vaccine series. Administer 3 additional hepatitis B vaccine doses at 6, 10, and 14 weeks.
Okay. The mother is negative. Usually the mother is negative, is it not? Okay. Yeah, do it.
If maternal status is negative, a birth dose of hepatitis B vaccine can be given to low birth weight and premature infants. For these infants, the birth dose should not be counted as part of the primary 3-dose series. And the 3 doses of the standard primary series should be given according to the national vaccination schedule.
What does he mean by telling that the birth dose should be given? But there's no difference, is it? A birth dose hepatitis B can be given at below 2 kg also. I mean, that's what they say. Now let's come to the same. Let me see. 1 minute. Now this is in another page, immunization special situation, the purple book, same book. Read what is given from the top.
In babies less than 2 kg born to a hepatitis B positive mother, hepatitis B vaccine should be given along with HBIG within 12 hours of birth, and 3 more doses at 1, 2, and 6 months are recommended. Since most developing
1
countries
minute,
employ...
wait here. But see, I'm going slow here. The same book, it is given somewhere else that the 3 more doses are given at 1 month. You can count it same as 6 weeks, is it not? 6 weeks is 1 month and 2 weeks. Therefore, you can give it 4 weeks also, no problem. Then they are telling another dose at 2 months and the rest at 6 months, not 6, 10, and 14 weeks, which is given in page 150. In page 466 on the same book, they say 1, 2, and 6 months. Okay. This is called the accelerated immunization. That is, you are giving the first 2 doses very close so that the child becomes immune. If a positive mother, okay. Therefore, remember that you may say something and the examiner may say, no. In hepatitis B positive mother, you have to give the first dose at 1 month and the second dose at 2 months. Okay, you can be wrong in that way. You can't be wrong in this. Okay, now go ahead now. Next.
Since most developing countries employ the UPI schedule of 6 and 14 weeks with a pentavalent or hexavalent vaccine containing the hepatitis B antigen, In 2017, the WHO recommended that a birth dose of the hepatitis B vaccine can be given to low birth weight and premature infants.
Okay.
For these infants, the birth dose should not be counted as part of the primary 3-dose series. The 3 doses of the standard primary series should be given according to the national vaccination schedule.
Okay, therefore that means that you can give birth dose to children below 2 kg. That's what they are telling, I think. And when should you give it is not given very clearly. Okay. Now, administer the 3 additional doses at 6, 10, and 14 weeks. That means that's what they are telling. You give by the birth, and then you give 6, 10, and that's what I understand. Now, let's therefore now see, look at what the CDC says. Read it now. Can you see it?
Yes, sir. Infants weighing less than 2 kg born to HBsAg negative mother should receive the first dose of the hepatitis B vaccine series at chronological age 1 month or hospital discharge. If hospital discharge occurs when the infant is younger than 1 month of age.
Therefore, CDC and vaccine immunization give like that. See, what's the point in giving at birth? Because we know that less than 2 kg is not that effective. SBSAG, we know it is negative in PRS hospital. Why should we give it? Now, why do they say that you give the last dose? Here you give it 14 weeks. Hepatitis B vaccination. What's the problems in hepatitis? We'll go through that. Now, this is the, I have discussed this earlier, 2025 immunization schedule by the CDC. And look at what is given here. The birth dose after 4 weeks, that is 2 months, it is given. Normally 2. Then it is given dose 2 to 3. There they give only 3 doses. Okay, read it. What is given? Children 4 months through 5 years. Dose 2 and 3. 8 weeks and at least 16 weeks after the first dose is given the minimum age for final dose in 24 weeks. Therefore, dose 1 and 2, there should be a minimum interval of 4 weeks. But for dose 2 and 3, there should be 8 weeks between the second and the third dose and 16 weeks after the first dose. And it should not be before 24 weeks. It should not be before 6 months age. Now read it carefully. What is given, what has come up now. I'm little...
Routine series.
Yeah.
3-dose series at 0, 1, 1 to 2, 0, 1 to 2, 6 to 18 months. Use monovalent hepatitis B vaccine for doses administered before age 6 weeks. Infants who did not receive a birth dose should begin the series as soon as feasible. Administration of 4 doses is permitted when a combination vaccine containing Hep B is used after the birth dose. Minimum age for the final, that's third or the fourth dose, is 24 weeks. Minimum intervals, dose 1 to dose 2 is 4 weeks, or dose 2 to dose 3 is 8 weeks, and dose 1 to dose 3 is 16 weeks when 4 doses are administered.
Okay.
When 4 doses are administered, substitute dose 4 for dose 3 in these calculations.
Okay, now what it means is the last dose should not be given before 6 months. That is 24 weeks. That's the most important thing. 3 doses are actually enough. 0, then you give it 6 weeks and 6 months. That is enough for the child. But we are giving 4 doses invariably because we are giving, what are we giving at now? Here, minimum age for the final dose. The most important point is that 24 weeks. I have discussed this several times. Faris, can you tell me why the last dose of the vaccine should be at 24 weeks? 6 months. Can you tell me? Amal.
So because of long incubation period.
Long incubation period, okay. That is a different matter altogether. Anybody else? Mohsin is not there. 2nd year, 3rd year. Gopika, can you help? Why do you give it at 6 months? You must be aware of all this. That's why I'm asking you this question.
Maternal immunity weans off by 6 months.
What is it?
Maternal immunity weans off by 6 months.
Okay, but then why? See, there is no problem in giving DPT, and the pentavalent vaccine contains many things. IPV, it contains diphtheria, it contains pertussis, it contains tetanus. All that you are giving 10 and 14 weeks. No problem. We are giving hepatitis B also at that time. But the WHO say that, but the CDC says you should give the final dose at 24 weeks for hepatitis B. Why? Hepatitis B alone, it says 6 months. And remember, I'll tell you that I have explained this before. Probably many of you were not there when I explained. I want to drive in this point. Therefore, that's why I am giving so much time for this. Yeah.
TRBs, yeah.
What's it? Anybody, if they know, can unmute and answer, please. Can you say? Well, you see, we require short-term and long-term immunity. Remember that in 16 months, 18 months, when you give the vaccine, now let's go on to, I will explain to you as the slides come by. This is the CDC immunization special situations. They say that if the mother is negative, less to give the first dose below 24 hours. See, more than 2 kg you give within 24 hours. This is hepatitis B schedule for children above 2 kg, below 2 kg. What's the difference? Okay, that's the most important thing. Therefore, if it is positive, we know what to do. If it is negative, if the child is about 2 kg, you give within 24 hours, no problem. The difference comes here when less than 2 kg, it is given at 1 month or hospital discharge, because the patients do not respond to your, if the mother is hepatitis B negative. Now, this may not be very much, I don't know whether they are doing the screening in the government sector. I think they are doing it now. Therefore, there's no need to give it at birth. You can give it when the child is at discharge or at least 1 month old. And then you give 2 months and 6 months discharge. Now, if you are giving it at birth, then you will have to give additional 3 other doses. That's what it means. Now, my question is, why is the last dose intended to be not before 8 months? That question will come up here. Now, here, if the mother is negative, single combination, hospital discharge, 2 months, 4 months, 6 months. That is what is given in CDC. Okay. Therefore, the last dose is given at, the final dose should be administered at 24 weeks. That is the most important point here. If you are giving it any time, any dose you give, the last dose should be given at 6 months. Now, if you look at the other thing, what is that? But if you give I think the rest is advisable. Now, let's go to the, I will deal with it slowly. Can you read it now?
Immunization in preterm or low birth weight infants continue. In babies less than 2 kg born to a hepatitis B positive mother, hepatitis B vaccine should be given along with HBIG within 12 hours of birth, and 3 more doses at 1, 2, and 6 months are recommended. Since most developing countries employ the UPA schedule of 6, 10, 14 weeks with a pentavalent or hexavalent vaccine containing the hepatitis B antigen, in 2017, the WHO recommended that a birth dose of hepatitis B vaccine can be given to low birth weight and premature infants. For these infants, the birth dose should not count as part of the primary 3-dose series. The 3 doses of standard primary series should be given according to the national vaccination schedule.
What is very unfortunate here is birth dose hepatitis can be given to low birth weight, even 1.5 kg. Is it that they mean for a hepatitis E negative child? This is because WHO looks at the public health. In public health, probably all the mothers may not be screened. Therefore, when they're unknown, they say you give. But you give a dose at 3 other doses. Should not count primary. 6, 10, and 14 weeks, you should continue. That's what it means. What the WHO says. Now, again, carry.
All other childhood vaccines may be given as per chronological age if medically stable infant while in hospital. Rotavirus vaccine, which should be deferred until discharge from the hospital to prevent the potential healthcare associated spread of this live vaccine virus, and has acceptable safety, immunogenicity, and efficacy.
This is very important because if the child becomes 6 weeks old, you might start giving rotavirus, but don't give rotavirus inside the SCABU. Okay, read it.
Full dose of the vaccine should be used. Since preterm low birth weight babies may have low muscle mass, the use of needle with lengths of 5 by 8 inches or less is appropriate to ensure effective, safe, and deep anterolateral thigh intramuscular administration. As preterm, low birth weight babies have increased susceptibility to infections. Vaccines such as PCV, rotavirus, and influenza should be offered if resources permit. Preterm babies are at increased risk of chronic complications from influenza. Immunization of babies age appropriate, as well as the immunization of HCPs, handling the babies, and all household contacts should be considered.
Now, let me tell you, I asked you a question. This is the last slide of this because I think the most important point I am asking you, why in hepatitis B they are insisting on 6 months? I have not got an answer from you. I'll tell you the answer here. Because remember, I have not put up the immunization schedule. I thought I put up the normal immunization schedule. You will find that there is no injection given at 6 months in our government or private. Okay. We give 6, 10, 14 weeks, and then we give the booster dose at 15 months. In the booster dose, in government series, hepatitis B is not there. There is no booster for hepatitis B because when children are given dose at 0, 6 months and 6 weeks and 6 months, or 2, 4, and 6 months, as is given in Western countries, there's no need for booster. There were no boosters given for hepatitis B, unlike other killed vaccines like diphtheria, pertussis, tetanus, etc., where we give a booster at 1.5 years. Now, hepatitis B, short-term and long-term immunity is very, very important. But somehow, therefore, if you are not giving boosters, will it be effective? Therefore, all studies have been done in hepatitis B with the last dose given at 6 months. And they have found that children, patients, adolescents at 20 years or adults at 30 years are still immune, are still protected. But no studies have been done when the vaccine has been given before that time. That is why hepatitis B vaccine, when it is given in 3 doses and no booster is given, then definitely the last dose has to be given at 6 months. And that's a problem with the government vaccination. Now, our consultants will tell you, don't worry, we are giving a booster at 1.5 years. Yes, it is true. They are giving a hexavalent vaccine at 1.5 years. Therefore, they are giving 5 doses of hepatitis B, not 4 doses. In our hospital, they get it at 0. They get it at what you call at 6 weeks, 10 weeks, 14 weeks, and they get it at 15 or 16 months also. They give 5 doses. Therefore, in that way, they are good, but they are giving 1 dose which is not required. So that is a problem here which you would suggest. Now, I would go out of this. I think this presentation is over. Okay, now I'm stopping the screen sharing. Let me go back. We will go into something called future vaccines. We have got, I think, 1 hour. I finished it earlier than I expected to. I will come back into the hepatitis B vaccine later or again, okay? Because that's a very important, this one here. Can you see the slide, please?
Yes, sir.
Okay. Now, let me tell you frankly that, see, I think many times what happens in the examination is one question has to be asked from vaccinology. Okay. Uh, Therefore, the examiner, when he puts an MD question or a DNB question, even for a matter future questions, he cannot ask you immunization schedule or something from, he might ask you what are the newer vaccines. As if you know everything about the old vaccine, which you did not. I myself did not know. If I ask you flatly, why is the hepatitis B vaccine not given at 6 months, should be given at 6 months, you're not able to answer. You're all very postgraduate students already. Even Amal did not answer. Therefore, because I'm telling Amal, because he's at the edge of writing the exam, he should, the most knowledgeable peak of your knowledge comes just before the exam. After the exam, it goes down unless you boost it with secondary immune response. Therefore, what are the future vaccine? It is given very well in vaccine which are newer vaccines which are coming up. And can you tell me the name of a few newer vaccines? Dr. Amal?
Dengue, Dengue, yes. Dengue,
Oh, dengue X. Then what else? Very good. Dengue vaccine. Anything else?
malaria vaccine.
Malaria.
Very good. Malaria vaccine. Therefore, you can be asked an essay on it and you can be asked to write. That's all, because from the practical point of view, it may not be very important. But anyway, future vaccines are given very well in Purple Book to a certain extent, but difficult to read it. That's what I would say. Therefore, this presentation is for that. Now, can you read it? Now, this is I'm just telling you how what is the mechanism of action of the vaccine. How are the previous vaccine used, etc. Now, can you see the slide now? You can, I suppose. The
Yes,
first
sir.
the first 6 slides I have taken actually from Pfizer's technology. It gives you how the live, I mean, I'm just giving you know all this, but I'm just giving you this. One is live attenuated vaccine. Therefore, live vaccines are what? Can you read it now? Can you read it?
Live vaccines are wild viruses or bacteria that have been weakened. In the lab, generally the virus is passed through many generations of cells to pick up the genetic mutations which weaken it. So much it won't cause disease in your body.
Therefore, this is the wild virus. Okay, read it. Wild, harmful wild virus genome. It is passed through.
Uh,
Virus picks up mutations over generations. The harmful weakened vaccine genome. Therefore, finally, the principle is read this. What's the principle? Read that.
Live attenuated vaccines target your body's immune system directly. They are strong enough to trigger the immune response, but too weak to cause disease.
That's the most important thing. They can cause the immune system, but antigens to stimulate the immune system. Very nice. Attenuated. You see. Hello. Attenuate. Amal, please mute your this thing. Huh? Attenuated means weakened. Okay, that's the thing. Now that's how it happens. Inactivated vaccine, you know how it happens. The virus is still using chemicals or heats, destroyed genome, not able to replicate. Inactivated virus, this produce an antibody response. Therefore, inactivated targets your body. This is a weaker than natural infection or live vaccine. So inactivated often require multiple doses. Okay, now the second is now comes what is subunit vaccine. Now I may ask you a question. You would have heard about subunit vaccine, subunit vaccine. What is subunit vaccine, Amal? Amal, you had to unmute and then answer. Amal is gone. Rose, can you answer? Yeah. What is subunit vaccine? Rose, you have unmuted, but I can't hear you. Ashwati, you unmute and answer, no problem. Others are, I can't hear them. Okay.
Sir, if only specific antigens are used to
Yeah.
stimulate the immune system.
Yeah, not the whole virus is not used. And can you name one subunit vaccine? Okay, now read it. Read it now.
What are the subunit recombinant polysaccharide or conjugate vaccines? Subunit vaccines use a portion of bacteria or virus to cause the immune response independent of its virus or bacteria of origin. Elements of subunit vaccines can be proteins, polysaccharide chains, or a combination of these. Protein vaccines. Viral proteins are isolated in a lab mixed with an adjuvant, immune system stimulator, and injected into the body to cause an immune response without the virus that makes you sick.
Okay.
Uh,
Yes.
First, vaccine released into the body, then protein taken up by antigen presenting cells and displayed on surface as antigen. Later, immune helper cells identify antigen and trigger a immune response.
The most important thing is subunit vaccines are what you call made from a piece of pathogen, not the whole organism. That's why. Therefore, the typical is hepatitis B, I think. Hepatitis B vaccine is typical of that. Okay, now come about this.
What are toxoid vaccines? Toxoid vaccines neutralize the toxic activity created by bacteria instead of harmful bacteria itself, neutralizing the activity which normally make you sick.
Okay.
Then vaccine target.
I think you know this very well. The toxin and the vaccine adjuvant enhancer, they may inactivate the vaccine target creating it is very simple. You know, the toxin is used. Where are we using the toxins? Which vaccines are made of toxoid?
Tetanus.
Tetanus and diphtheria. Okay, and the stock. So that's why they say that one of the reasons they say if you get diphtheria or tetanus, you don't develop immunity is because the antibodies are towards the toxoid and not to the organism. Therefore, you can again get infected with diphtheria or tetanus because the antibodies are toxoid. But that's not the only reason, but that's what it is often said. Tetanus and diphtheria vaccines, which are classical. Now comes more important question, viral vector vaccine. What is viral vector vaccine? Can you say that?
made of Made of a small section of a virus genetic material, the instruction or the blueprint for the specific protein. The viral capsule or shell from another virus carries the gene safely to your cells.
Yeah, here is the target virus genome. It is harmless virus genetic material. Gene or specific protein is capsulated in this. It is carried in gene protein blueprint carrier virus. There's a carrier virus gene capsule or skin taken from another virus. Now the AstraZeneca and Johnson COVID virus vaccine carry genetic code for the spike protein. That's COVID vaccine is time at which these viral vectors became very important against invaders carrying the spike. Therefore, genetic blueprint is there. They carry target spike protein, virus capsule from different viruses. Now, why is this important? Can you read this?
Viral vector vaccine. Viral vector vaccines use a harmless virus to deliver the host cell the genetic code of the antigen you want the immune system to fight. They are basically the gene delivery system. Benefits. Viral vector vaccines usually trigger a strong immune response. Typically, only one dose of the shot is need to develop immunity. Boosters may be needed to maintain immunity.
You see,
Examples: Ebola vaccines, COVID-19 vaccine.
AstraZeneca. See, AstraZeneca vaccine is the one which was available as Covaxin here, I think, is it not? We all took Covaxin, I think, at that time. It was manufactured by Serum Institute. Am I right? I think so. Therefore, the thing here is that you are putting it in another virus the gene protein, and package in a capsule of another protein. You want the immune system to fight. They are very more effective. That is, you can simply target a particular protein because now genome analysis is done. You can find out the genes which manufacture the spike protein and put it in that and maintain the viral vector, usually trigger a strong immune response. Only one dose is needed to develop immunity. Therefore, there's a question whether viral vector live vaccine or kill vaccine. Actually, they are packaged in a protein capsule. Would do these virus multiply? I'm not too sure. But therefore, there was always a question whether boosters are needed or not. Though they produce very high antibodies, boosters may be needed. Remember this. So that's why COVID vaccine first there was one dose, and later on booster became important. Now, what is messenger? This is the most important reason multiplication. What is that? Read it. Ashwati, can you read it?
Yes, sir.
Yeah.
Vaccine target. Precise mRNA COVID vaccine carries the genetic blueprint for the spike protein.
Blueprint
This
for
protein
specific
and
protein.
your body will make this protein and build immunity against any invaders carrying it on their surface.
Therefore, this is a viral genome. Okay, the gene for specific protein packaged in a capsule, gene protein blueprint, insoluble nanoparticle. There's a nanoparticle. Therefore, what happens? The genetic blueprint for spike protein, therefore, looks like the other one, but you read this messenger RNA vaccine, read what is given here.
Messenger RNA vaccines. One of the newest and the most exciting areas in vaccine technology is the use of mRNA vaccines. Unlike conventional vaccines, which can take many months or even years to cultivate, mRNA vaccines can be developed quickly using the pathogen's genetic code. Benefits: it's a very powerful technique to be able to create a lot of vaccine fast. The benefit is that the technology is very adaptable. We can potentially go in and change the mRNA in the formulation to target a new antigen and can make a lot of high quality vaccines material relatively quickly. Examples: Pfizer BioNTech COVID-19 vaccine.
Yeah, this is Pfizer's vaccine, which is available in the world. Now, you must understand what's the advantage of messenger RNA is. You are the messenger RNA, which makes in this case, the protein, which is this called TARG spike protein, is put on in a carrier, in a virus, and immunized. Therefore, the messenger RNA starts manufacturing very fast these spike proteins, and antibodies are developed against this. Why don't you put the DNA? Why you want to put the messenger RNA? Can you tell me? DNA template. Why do you put the messenger RNA? Because normally messenger RNA, there is something called reverse transcriptase. Normally, DNA becomes messenger RNA, original DNA. But here, the messenger RNA is given by reverse transcriptase. It starts affecting the DNA of the host cell. This is a very new mechanism for which they got the Nobel Prize, etc. But what happens is you have a genetic code, you can put it in anything and start manufacturing huge amount of spike proteins. Now, if you want to change it, you think that this is not working, something else start working, then you can go in for that change. Therefore, the messenger RNA, this is the most important thing. Exciting, unlike conventional vaccine, which can take months or even years to cultivate, messenger RNA can be developed quickly using this pathogen genetic code. It's a very wonderful technique to be able to create a vaccine fast. You may be asked, why don't you introduce the DNA? Why you are introducing the messenger RNA? Because when you use the DNA, it may what you call change over a period of time and start producing the disease in the patient. Therefore, you are more happy to give the messenger RNA in that. There a lot of material is there. It can be asked. Now we just go through the technology once more. Amal, can you read it?
Yes.
Yeah. I can't hear you. You're not unmuted. Yeah.
In the early stage of modern vaccinology, vaccines were produced by the empirical approach, which consisted of isolate, inactivating, and inject the microorganism that causes the disease. Many of the highly successful vaccines, such as diphtheria and tetanus, toxoid pertussis, rabies, influenza, smallpox, polio, and Bacillus calmette-guerin BCG vaccine, were produced utilizing this technology. This was followed by the period of recombinant DNA vaccine and the glycol conjugate vaccine. Reverse vaccinology, which was the first successful platform in the genomic area, resulted in the successful vaccine against the group B meningococcus.
Okay. These are very little. We are going into little. Recombinant DNA vaccine is something you would have heard about it. Do you have any idea what it is? Okay, let's go ahead. I am myself not very good at it. Go ahead about it. Read the next slide. Change.
Change.
Yeah.
Change.
Yeah.
Several new platforms are in development and some are in use. These include DNA vaccine, mRNA vaccine, viral vector vaccine, and chimeric vaccine. The rapid development of COVID-19 vaccine have resulted in some of these platforms entering clinical usage, with vaccine utilizing hidden epitopes, which are generally less immunogenic. There is a need for the potent adjuvant that are also capable of skewing the immune response to a T helper cell one type. Some of the novel adjuvant like MF59 liposomes, saponins, toll-like receptor TLR agonist, and oligodendron nucleotides.
What is epitope? What do you mean by epitope?
The part of viral antigen which is not immunogenic.
I think it's the other way around. The part of
And the
the gene
antigen,
which is more one part of a gene which is more immunogenic. That's what you like to target, that particular point in the gene, not the whole gene. That's what I understand. Now here, all these have come about. These include DNA, RNA, virus, viral vector vaccine, all came about very rapidly in COVID-19 vaccine, because previously they were not giving what you call approval. It may take 10 to 12 years before a vaccine is approved. But as far as the COVID came, they accelerated the whole thing and it became very fast. Therefore, the DNA viruses, messenger RNA viruses, viral vectored virus, which is Covaxin, messenger RNA vaccine, which is Pfizer's vaccine, DNA vaccine, which I said is not so common. We will read about it in DNA. Now, that's it. This I will leave it now. What is reversed vaccinology? If you can understand it, it will be very good. Read it now. You can be asked a short note of reverse vaccinology, because given in from where I took it, I am not too sure. Okay, read it.
reverse vaccinology is defined as an innovative approach to vaccine development that utilizes the bioinformatics and computational analysis to identify potential vaccine target within the pathogen genomes, allowing for the modeling of the epitopes and the creation of tailored vaccines for improved efficacy and safety. Reverse vaccinology is a new approach to designated vaccine that combines our rapidly increasing feasibility to sequence whole genome of the microorganism and apply bioinformatic analysis to those data. Predictive modeling identify new pathogen target that are ideally conserved and target of protective response. The subsequent expression of a candidate target for the screening by the use of using human serum from those with effective immunity and for the evaluation in median models can lead to design of optimal vaccine, particularly to the bacterial pathogens.
Okay, it's a little tough to understand, but with the example of what you call the next slide, where they give you an example. What I understand is that innovative approach to vaccine development that utilizes potential vaccine target, that is which against antibodies against which gene or which particular protein will produce immunity. That is identify potential vaccine target within pathogen genomes, allowing for the modeling of epitopes, creation of tailored vaccine for improved efficacy in vaccine. They just don't kill the organism and produce an antibody against the whole organism or a subunit. They first identify the particular part of a gene in which antibody will be protected. Designing back that combine a rapidly increasing feasibility. Anyway, you read it. Now we'll go to this and see. See, one of the vaccines which we have is meningococcal vaccine. Now, meningococcal vaccine, quadrivalent vaccine is available in the market. It contains it. It targets A, C, and then it targets also W and Y, I think. W and Y or W and X. Therefore, four targeted. But Neisseria meningitis B is not available. I don't think is available in India, but it causes a lot of mortality in the UK. Therefore, they were having problem in developing a vaccine to it. You read it now, and they achieved it through reverse vaccinology. Carry on. Read it now.
Neisseria meningitis serotype B causes quickly progressive meningitis with high mortality. Unlike the other strains of meningococcus, its capsular polysaccharide sialylated like human glycoprotein, interfering with the ability to create a typical conjugate vaccine. Genomic sequencing of meningococcus serotype B lead to identification of 90 new surface antigen, of which 30% bound to serum antibodies from immune patient. Subsequent murine models with selected antigens demonstrated effective protection, and ultimately these antigens contributed to development of currently available meningococcus B subunit vaccine. A variation on this approach using computational analysis of binding site of neutralizing antibodies to the respiratory syncytial virus RSV lead to formulation of a recombinant immunogen that, when combined with an adjuvant, demonstrate the protection in animal models.
Therefore, here you understood what is reverse vaccinology. You understand. You cannot, is normally what you do when you have a protein, you conjugate it and then make a conjugate vaccine. You didn't, that's what we did in AC, what they did, we didn't do it. They did it in quadrivalent meningococcal vaccine, but they couldn't do it for technological reasons to be. Therefore, what they did the genomic sequencing, and they found out that there are 90 new surface antigens. Now, whether these antigens will produce antibodies which are protective is not known. For what they did, patients who were immune to the group B streptococcus, they added the antibodies and they identified the surface antigen to which it bound. Okay. And that particular antigen, 30% of the 90 antigens, 1/3, that means 20, they used to produce a subunit. Only that particular antigen they took out. That's how they made that's called reverse vaccinology. Similar things are being used for respiratory syncytial virus also. Therefore, know the term reverse vaccinology. Amal may have escaped, but when you go for theory, you can be asked a short note about it. It will be a very tough question, but know something about it from the slides. Now, you said dengue vaccine is very important. Amal, if I ask you in the oral, what do you know about dengue vaccine?
Two types of vaccines are available. Dengue, which is only given if a patient is previously got dengue infection.
Okay. And then?
These are more commonly benefited in areas where dengue fever is endemic and result in high mortality.
Okay. All right. Next, what else do you know? Is it available in India?
It is in a stage 3 trial.
Stage 3. Is it available anywhere in the world?
Yes, sir.
Where? Is it given anywhere in the world? What does WHO say about it? Rose. Where is Rose? Rose is gone. Rose, are you there?
ഉണ്ട് സാറേ.
ഉണ്ട്. എന്നാ വായി തുറക്ക. എന്താ what say dengue vaccine is it given in Aster? അല്ല, yeah. എന്ത് പറയുന്നു? Is it available or not available?
Not available.
It's not available in India. Actually, I asked a question in the IAP Trivandrum. Is it available in anywhere in India? And nobody answered except Dr. Praveen. He replied to me telling it may come in the next year. Now, you say, see what happens when you read a new vaccine is they will give you the name of 10 vaccines, stage 1, stage 2, stage 3 trial. These you cannot remember. That's not what you should remember. For example, dengue and malaria, you should know whether it's available in India, what's the present stage, what does WHO say about it, is anywhere in the world it is given. These are questions. And Amal is about to appear for his DCH in pediatrics, and soon he will become a consultant, goes to a primary health center, somebody DMO will ring up and say, doctor, can we give dengue vaccine? You should know it's not available. Is it advisable or not? What does the WHO say? Anyway, you now carry on now. We'll read it fast and quick. Who can I ask? Gopika, can you read it fast? Gopika, you're there?
Yes, sir. But my daughter is.
Yeah, she will also start reading. Okay. Then you do one thing, ma'am, mute, and I will ask Rose to read it for us for a change. Rose, can you read?
Vaccines. There are currently 2 licensed dengue vaccines, Dengvaxia, Sanofi, and Qdenga. Both are tetravalent live attenuated vaccines, but differ in the extent of chimerization and genome backbone, as well as in efficiency and safety. Another tetravalent live attenuated dengue vaccine developed at Laboratory of Infectious Disease at National Institute of Allergy and Infectious Disease in United States is in the late stage of clinical development.
Okay, remember 2 licensed dengue vaccines, but they differ. What is chimerization means what? Chimerization means contain genes from 2 different species, 2 different viruses, species of virus. Anyway, remember the most important word is a tetravalent live attenuated vaccine. Remember this. Okay, now. Okay, read
Dengue,
it.
Dengue, a mosquito-borne disease caused by one of 4 dengue virus serotypes of the genus Flavivirus is still a growing public health problem. Immunity induced by primary infection is believed to induce lifelong protection against the infecting serotype, homotypic protection. In contrast, the cross protection afforded against other serotypes, heterotypic protection lasts on an average several months to 3 years. However, beyond this grace period of waning cross protection, there is an increasing risk that severe disease will result from a secondary heterologous infection. That is, infection by a different dengue virus serotypes to that which caused the primary infection.
Yeah, there is something very funny about dengue virus. That's what this is. I have taken. Maybe it's given in many other books. I had taken up from the PGI Tips Kerala Presidential Action Plan, but they have copied it from somewhere else, of course. You see, if you get a secondary infection, you can be in more danger. The second attack of dengue can be more dangerous than the first attack. That normally does not happen because it contains 4 serotypes, and the immunity of the primary infection is, if I develop dengue 1, then the dengue virus 1, I may get a lifelong infection protection against dengue 1, virus 1. But dengue 3 and 4 especially, called heterotypic protection, will last several months to 3 years. 3 years later, I get another dengue with, say, 2, 3, or 4. It will be more severe than the first one. Therefore, the second attack will be more severe than the attack. However, when you get a second attack, the third attack will be less because it produces antibody against all the 4. It's a very interesting immunology. Okay, carry on. Rose, can you read?
This increased risk of secondary infection is linked to non-neutralizing enhancing antibodies that facilitate virus uptake through FCM receptors by the mechanism known as antibody-dependent enhancement, or to a detrimental inflammatory or biased T cell response. During a secondary heterologous infection, memory B cell response not only preferentially recall serotype-specific response against the serotype responsible for the primary infection, but also boost and further induce the production of cross-reactive antibodies. And this result in more efficient cross-protection against subsequent, that is tertiary or quaternary infections, which are then less likely to be severe regardless of the infecting serotypes.
Very interesting, is it not? You see, why is it so? It can be asked, is linked to non-neutralizing enhancing antibodies that facilitate virus uptake from the FCM receptor. I don't know. FC receptors by a mechanism known as antibody-dependent enhancement, or to a detrimental inflammatory biased T cell response. Whatever it is, secondary infection is non-neutralizing antibody that there are certain non-neutralizing the neutralizing antibodies against the heterologous proteins decrease. Non-neutralizing antibodies are still there. They what you call antibody-dependent enhancement. The virus is more likely to be attached to the FC receptors, and they are more likely, but to have a more severe infection to the other dengue viruses. But the funny thing is, when you have a second infection, the memory cells are stimulated, and then it has protection for all the 4 types of dengue. Therefore, if I have 2 attacks of dengue, I will have protection always for all the 4. But the second attack can be more serious than the first attack. You read it again and again and try to find out. Last sentence, Rose.
So a protective vaccine should preferably induce an optimum immune response comparable in level and quality to that induced by a secondary dengue virus infection, which result in more efficient cross protection against subsequent infections with all dengue virus serotypes.
Okay, now it should act like a secondary infection. It's not like a primary infection we give. Okay.
The optimal immune response should
Yeah.
not only include neutralizing antibodies against different serotypes, with both specific and cross-reactive neutralizing antibodies being induced at high enough values and affinities to be effective, but also induces the production of moderate levels of pro-inflammatory cytokines, type 1 interferons, chemokines, and cytokines that link the innate and adaptive immune response. Similarly, at the T cell level, a vaccine should induce serotype-specific CD4 T cell
responses. What happened? We can't hear you. You're gone offline. I think she has gone offline. Similarly, at the T cell, a vaccine should induce. Amal, can you read it?
Similarly, the T cell level, a vaccine should induce serotype specific CD4 plus T cell or CD8 plus T cell response directed against both structural and non-structural antigens with no overt inflammatory profile. In seropositive individuals, the response to the first natural infection following vaccination is as it was a third or later infection and not associated with a high risk of serious disease. So, administration of vaccine in seropositive individual mimics an attenuated and subclinical secondary infection with a heterotypic dengue serotype, so that subsequent infection would correspond to tertiary or quaternary response, which are less likely to be severe.
Okay, this much I took it from IAP plan. They have put it up for PGs. They might ask you, why is the vaccine more effective, more patient? Normally, we give vaccination for patients who are serologically negative. In dengue, it's better to give it to a patient who's serologically positive. Why in the hell is it like that? It is because the vaccine acts as a secondary infection and produces heterotype antibodies against all the 4 dengue viruses. Therefore, when you get a third infection after that, first is the natural infection, second is your vaccine, third is the second natural infection, you are well protected. Now, if you understood it, is great. If you didn't understand, go back to a slide and read it carefully. But please understand one thing, the dengue vaccine for seronegative patients is not advised. At least the first vaccine which was discovered, which is called dengue virus, I think is not advised. Now we'll go into it. Okay, read it. I think
Combined with
yeah,
Combined with
okay. Rose, read it now.
Combined with vaccination of seropositive individuals, vaccination of seronegative individuals result in the production of lower levels of antibodies and high risk of severe disease in those who go on contract with the disease. The plausible hypothesis proposed for this is that vaccination primes the immune system like natural infection, and that after a period of protection following vaccination, immunity wanes, and among the seronegative individuals, the response to the first natural infection following vaccination may act as a second infection, which has typically been associated with
Higher risk of serious infection.
high risk of serious disease.
Okay, now I think I have gone into the mechanism of it from the in detail to make you understand. People who are going to appear for DNB, especially Rose and Margit, should know it. I think the DCH candidates should know that the mechanism they may not go, but in dengue, it's a very funny thing that you are vaccinating the persons who are already seropositive, not a negative person. Now we will go into the individual vaccine. So far, we were going into the immunology. Now read it, Rose, you can continue if you are online. Yeah. I think she's in and out of it. Ashwati, can you read it? Ashwati, can you hear? Yeah. Nobody wants to read, I think. What happened? Amal, can you read it?
Yes. Dengue virus vaccine, Dengvaxia, also referred to as CYD-TDV, is a live recombinant tetravalent dengue vaccine developed by Sanofi Pasteur. The vaccine schedule consists of 3 doses administered 6 months apart with an indication for individuals aged 9 to 45 years or 9 to 60 years, depending on the country's specific regulatory approval, living in dengue endemic countries or areas. Dengvaxia was first licensed in 2015 due to occurrence of vaccine-induced antibody-dependent enhancement in 2018. The WHO issued a fresh recommendation for its use. The WHO recommended that only persons with evidence of a past dengue infection should be vaccinated based on the antibody test or on a documented laboratory confirmed infection in the past. Where pre-vaccination screening is not feasible, the vaccine should be administered only those areas where vaccination recent serosurveys have a documented seroprevalence rate of at least 80% by the age of 9 years.
Therefore, these are things when you are asked about dengue virus, you should be able to talk or write for a short note or something. These are important points. Lifetime point, 3 doses, 9 to 45 years, some place 9 to 60 years. And it is given only if they are serologically positive or even high endemic areas where it has been documented seroprevalence at least 80% by 9 years. Now, what is a good thing about my presentation is these PowerPoint you can use for revision, and the important points are highlighted. The rest of it you might come with memory. Therefore, if you know the important points, you can write it. No, you are never going to give a viral vaccine dengue in a recent past anyway. Now let's go ahead.
Infection-acquired immunity following infection, the one dengue serotype antibodies that are serotype-specific, homotypic, or cross-reactive with other serotype heterotypic are induced. Following a primary infection with one dengue virus serotype, a long-lasting homotypic protection is elicited. Cross-reactive heterotypic protection, however, is short-term, declines rapidly within a matter of 2 years. As heterotypic protection wanes, there is a risk of severe dengue following second infection with another serotype. Severe dengue may also occur in infants with circulating heterotypic antibodies, passively acquired from dengue immune mothers.
See, Dr. Rose and Dr. Amal should, especially Rose, should note that where the where references. See, our purple book of vaccinology, and it has come in 2022, if I'm right. Therefore, it should have been printed and produced in 2021. Therefore, it's at least 4 years old. Now, WHO has come about with a position paper on dengue vaccine on May 2024, and the IAP PG tips has come in 2023. Therefore, I have quoted from there more than the purple book. The purple book is little confusing because it's if I would prefer for you to read from the WHO position papers. If you don't have time, you refer to my presentation. Okay. Read it, last line.
Following recovery from a second infection, a broadly protective immune response is induced, and severe disease following a third or fourth infection is rare.
Okay, carry on fast, you read here.
In clinical trial, CYD-TDV has been shown to be efficacious and safe in persons who had a dengue virus infection in the past, seropositive individuals, but increases the risk of severe dengue in those who experience their first natural dengue infection after vaccination, seronegative individuals. For countries considering vaccination as a part of dengue control program, pre-vaccination screening for past dengue infection is the recommended strategy. Using this strategy, only person with evidence of past dengue infection based on an antibody test or a documented laboratory confirmation should be vaccinated. If pre-vaccination or screening is not possible, vaccination should be limited to areas that have a recent documentation of a seroprevalence rate of at least 80% by 9 years of age.
Okay, now these are all repetition. Yeah, go ahead.
Pooled analysis of data from the earlier trials show high vaccine efficacy against symptomatic dengue, hospitalized dengue, and severe dengue in children aged 6 to 8 years who were baseline serotype. Based on this data, labeling updates were approved by the European Medicine Agency and included in the WHO vaccine pre-qualification information sheet. The labeling update included the lowering the age indication to 6 years of age from their earlier 9 years. Additional guidance on eligibility based on the pre-vaccination screening for sero status, the recommendation for co-administration of the vaccine with human papillomavirus, tetanus, diphtheria, and acellular pertussis vaccine.
Okay. They are lower the age of 6 years. Okay, that's the most important thing. Okay, in this.
Because of the need for pre-screening before vaccination, the use of CYD-TDV vaccine in National Immunization Program has been very limited. This position paper focuses on the newly licensed TAG 003 vaccine.
Okay, after giving us so much information, dengue vaccine, Sanofi's, they say that WHO has lost interest in that because you can give it only in patients who have had one attack of dengue. Therefore, you have to do antibody titer, which is not very feasible in public health. Or, I mean, you have to give it only in high endemic areas. Therefore, now they are closing in on the TAC vaccine. Now we will go into that. Takeda vaccine. Okay. Carry on.
Takeda vaccine efficacy is 80.2% against virologically confirmed dengue and 95.4% against dengue leading to hospitalization. In those who were seronegative at the baseline, the vaccine efficacy was 74.9%. And the incidence of serious adverse events
Well,
was
leave
similar
leave
in
that
the
paragraph. Go to the next one.
In August 2022, Takeda Dengue vaccine, dengue tetravalent vaccine live attenuated, received approval in Indonesia for the use, regardless of prior dengue exposure.
Therefore, that's a question I asked. I asked you a specific question. Has dengue tetravalent vaccine been approved anywhere? It is approved by in Indonesia for use regardless of prior dengue infection. Okay, remember this.
The WHO
Okay.
said that it has cleared a pre-qualification Takeda
Let me tell you one thing,
pharmaceutical.
Dr. Amal, let me tell you one thing. It is in 2024 is a paper report, Reuters paper report, which I have quoted here. The WHO, now read it, 2024, yeah.
The World WHO said that it has cleared pre-qualification Takeda pharmaceutical vaccines. Takeda vaccine given in 2 doses over a 3-month interval protect against 4 serotype of dengue virus. It was cleared by the WHO for use in children aged to 6 to 16 in areas with high infection rate. The pre-qualification makes it eligible to procurement by the United Nations agencies like UNICEF and Pan American Health Organization. The short branded Dengue is already approved in countries like Indonesia, Thailand, Argentina, Brazil, and was authorized in European Union in 2022.
Now, this is a paper report, but no doubt it's very significant because WHO has pre-qualified it. Okay, pre-qualified it means now any country can simply, nobody can sue if the Indian government approves it. Okay, that's the most important thing. And the other thing, already many countries are going ahead. And in fact, in this report, it is said that what they call the Takeda Pharmaceuticals B vaccines in India, they are negotiating with them for mass production in India for the whole world. Therefore, Takeda vaccine may come up. But the most important question is, has WHO pre-qualified it for patients who have not had a primary dengue? Now, they say in Indonesia, they have agreed to give it to everybody because it's a high endemic area. Now, in low endemic area, what's the vaccine? WHO position, okay?
Vaccination against dengue should be viewed as a part of integrated strategy to control the disease, including
sorry. Okay, yeah.
Vector control, proper case management, community education, and community engagement. Tab 3 does not prevail all cases of dengue. Comprehensive vector control must remain a critical component of dengue control program. Furthermore, mosquitoes of dengue transmit other important viruses, including yellow fever, chikungunya, and Zika virus.
This is what I don't understand. They said it's a quadrivalent live wire vaccine, and they say this does not prevent all cases of dengue. It will come up again and again, that point. Okay. This is WHO position paper on dengue. You should read it because dengue is a new vaccine, and they come up with a position paper 1 year ago. Okay. Continue, yeah.
WHO recommended that countries consider introducing Tag 3 into their routine immunization program in geographical location where high transmission intensity of dengue poses a significant public health problem. Many countries may have a heterogeneous geographical distribution of dengue transmission intensity, could consider a target subnational introduction. Until the efficacy risk profile of dengue virus 3 and 4 in seronegative person has been more thoroughly assessed, WHO does not recommend the programmatic use of Tag 3 vaccine in low to moderate dengue transmission setting.
Okay, now this is the most important point which has come about. Though Indonesia has gone ahead and introduced it, probably the whole area is full of high level of transmission. India will not be able to do it because WHO has said only in high, does not approve for it for low to moderate dengue transmission. Therefore, unless suppose there is a high amount of dengue in a tribal area, which is a forest area, and you have done a study, seroprevalence is more than 80%, you can do a subnational immunization there. You cannot go and immunize, don't go and immunize in the population in PRS hospital or something. Because 2 days from now or 1 month from now, may come, doctor, the dengue virus vaccine has come. Shall we give? No, you cannot give unless you have done it. Therefore, WHO does not approved. There are certain countries which have approved. Definitely, you will wait for the WHO pre-qualification to occur. The most important point is there. Okay. Read.
To determine the extent of dengue transmission intensity, countries should consider the data on age-specific seroprevalence and or age-specific dengue hospital admission. There is no precise age-specific seroprevalence threshold above which vaccination is indicated. The benefit of vaccination will increase with the increasing seroprevalence, with better vaccine performance being expected in seropositive person. Threshold cutoff for minimal seroprevalence to initiate vaccination should be decided by the countries, typically by an SP9 of more
I
than
didn't
60%.
understand what that 9 means. Okay. I'm sorry about it. I just copied and pasted. Okay. Okay.
Would
Yeah.
be considered an indicator of high dengue transmission. In addition to a mean age of peak, dengue-associated hospitalization of less than 16 years could be considered as an indicator of high dengue transmission. The use of a pre-vaccination screening strategy to limit vaccination to seropositive person is not recommended in setting with high dengue transmission, as this would substantially reduce the public health impact of vaccination and increase the programmatic costs. Target age group recommended the use of TAG3 in children aged 6 to 16 years in the settings high dengue transmission intensity. Within this age range, the vaccine should optimally initiated about 1 to 2 years before the age-specific peak incidence of dengue-related hospital admission, although the programmatic alignment with administration of other school-based vaccination and health intervention is also an important consideration. Catch-up vaccination can also be considered for other age group within the 6 to 16 year of age range at the time of vaccine introduction.
The 6 to 16 years.
16-year age range at the time of vaccine introduction.
Okay, 6 to 16 years, the range, 2 doses, I think 3 months apart, is it? What was the mentioned? The main points you catch, okay? It is not recommended. WHO has still not recommended it for this one, and I don't know whether. Anyway, let's go ahead and vaccination schedule is coming up. We read it.
Vaccination schedule. The
Sorry,
vaccination
sorry.
is recommended.
Yeah, go ahead. Yeah.
The vaccine is recommended as a two-dose schedule with a minimum interval of 3 months between the doses. It is not advised to reduce the interval between doses. If the second dose is delayed for any reason, it is not necessary to restart the series, and second dose should be administered at the first available opportunity. Booster dose. Weaning of the vaccine efficacy was observed over 5-year trial period. There are currently no data on the use of booster dose. Additional studies are underway to determine the use of a booster dose and its optimal timing. Accordingly, a booster dose is not recommended. WHO position co-administration. Available evidence support the co-administration of TAG3 with yellow fever and hepatitis A vaccine studies to assess co-administration of HPV vaccine are ongoing. Inferring from co-administration studies of other vaccine, TAG3 may be co-administered with other inactivated subunit for mRNA vaccine except for live vaccine, for which more data are required.
You cannot give with other live vaccine. Why? We normally give MMR today, but they have been studied. But this is a new vaccine. It has not been studied whether you can give it with MMR and other live vaccine. Remember that, okay? Can you read?
Special settings and population. Pregnant and lactating person TAG3 is not recommended during pregnancy, and pregnancy should be avoided at least 1 month following vaccination. Inadvertent vaccination of a pregnant person is not a reason to terminate the pregnancy. It is unknown whether TAG3 is excreted in human milk immediately after administration. A risk to newborn infants cannot be excluded. Until such data become available, vaccine is contraindicated for mother during breastfeeding. Immunocompromised person, TAC3 is a live attenuated vaccine. TAC3 is contraindicated in person with congenital or acute immunodeficiency.
Go through this very carefully. Now, normally you would never say anything is contraindicated in lactating mother. We saw yellow fever is vaccine is contraindicated, and you cannot, you should not, if you give, be lactating for at least 1 month after you give a yellow fever vaccine. Here it is contraindicated, vaccine contraindicated mothers during breastfeeding. The second vaccine, because no studies have been done. Therefore, they are keeping it quiet. And also in pregnancy, live vaccines are generally avoided in the 1 month. Therefore, but remember, pregnant mothers are more prone for dengue complications also. Yes, go ahead.
Person with comorbidity such as sickle cell anemia, diabetic hypertension, or underlying comorbidities that may result in bleeding tendencies, example ulcerative colitis, are at higher risk of more severe disease outcome when infected with the dengue virus. People with such comorbidities are generally older. Person with comorbidities who live in dengue endemic countries could be offered vaccination even if fall outside the recommended age range for the programmatic use, 6 to 16 years, provided a substantial country-specific burden of a severe dengue outcome in this population has been documented. Such individuals need to be informed that vaccine may not confer protection against dengue virus 3 and 4 in seronegative vaccine recipient, and with currently available data, the potential risk of severe dengue cannot be ruled out if seronegative persons are exposed to dengue virus 3 and 4.
They say quadrivalent vaccine effective and all that, but they say zero. You have to be careful for dengue virus 3 and 4. It may not be effective. Okay. Persons with comorbidity, sickle cell anemia, or patients with diabetes and hypertension, it can be given outside the 6 to 16-year range. That's what they say. Last sentence, can you read?
Until more data on the efficacy safety profile become available, WHO recommend the lower age limit of 6 year and upper limit of 16 year for the vaccination.
All right. Now, travelers, that might be the last one. Quickly read it here. See, I'm not interfering. I'm not giving much explanation because dengue fever, you should know dengue. You must know something to write a short note or even an essay of a newer vaccine. They were not likely it is of any practical significance because it's yet not available in India. Okay, travelers, read it.
Persons living in non-endemic countries who have previously been infected with any of the 4 dengue virus serotypes following travel to dengue endemic country may benefit from TAC3 vaccination to prevent second and hence potentially more severe dengue infection when traveling again to the endemic country. Frequent travelates, long-term travelates, migrants, and long-term expatriates have a high likelihood of previous dengue infection and therefore more likely to be seropositive compared to first-time or short-term travelates. The benefit of vaccination with TAC3 are lower for travelates who have never experienced dengue infection and are therefore seronegative compared to travelates who are seropositive.
Okay, I think it's all self-explanatory. Therefore, okay.
Travelers need to be informed that vaccine may not confer protection against dengue virus 3 and 4 if they are seronegative and there is a potential risk of severe dengue virus. Dengue if seronegative individuals are exposed to dengue virus 3 and 4. Travelers also need to inform that transmission of dengue is heterogeneous within the country and circulating serotype may vary during different periods. The highest benefit with lower risk during an ongoing epidemic due to dengue virus 2 or 1 is the destination, although pre-vaccination risk screening to determine serostatus is not required where applicable, its use could be considered to inform assess the risk and benefit.
Therefore, this can be a question in your oral. They can ask you, doctor, you are going to go to tomorrow to a place in Jharkhand, or you're going to go to a place like outside India to an African country where, especially in Indonesia and all those places, there's a very high dengue fever. The examiner can ask you, doctor, you are going, your child is going, a family is going, would you advise them to take the dengue virus vaccine if it is available? The answer is, if it is possible to do a screening, it's better to do a screening. And if you are positive, you can take it. But explain the risk that 0, 3, and 4 can be more severe in that. DNV 3 and 4 may not be protected by TAC vaccine. And then you can also tell them that if you are negative, it is better not to take the vaccine. That's how it is. Yeah. Read it.
Protection started 14 days after the first dose has been demonstrated between first and second dose. Hence, the first dose can be given up to 14 days before travel to dengue endemic country. To ensure the durability of the protection, second dose is needed after a minimum interval of 3 months. Until more data become available on the efficacy safety profile, WHO recommended a lower age limit of 6 years and upper limit of 60 years for the travelers. Health worker generally not a greater risk of dengue. Health workers should be up to date and vaccines are recommended in their national immunization schedule. Outbreak response and dengue transmission to dengue endemic countries is characterized by cyclical pattern, typically peaking every 3 to 5 years, with varying serotype dominance and increase in the frequency and magnitude of outbreak has been observed in recent decades. A preventive strategy to routine vaccination is more impactful than a reactive campaign in response to outbreak.
Valara, this is the last sentence, the last slide is very important. If you ask people like Dr. Anju, she will tell you, Dr. Ipa, we don't see dengue like before, because before, when I came, even in 2018, you would find many patients. We didn't have a high dependency, many patients on hypotension, many patients on dengue with decreased urine output, where the fluid management becomes very important. Therefore, it was really worrying. And in fact, Dr. Anju has told me that they have transferred patients with severe shock and all that, none of which you are seeing this. But don't think that it is over. Remember, whenever somebody tells you, tell them dengue is cyclical. It comes once in 6 years, it might come as an epidemic, and then it again comes back. Therefore, then people might tell you, okay, we will vaccinate before that period. No, routine vaccination is more impactful than a reactive campaign in the response to an outbreak. Now, dengue fever, we have finished. We have overstepped the time by 12 minutes. I think at least you were not, I would have expected some more people to attend. But anyway, the people who attended did not run away, at least, because of calls. If I'll stop the 1 minute, I'll stop the recording here. Okay. Into recording. I'm not able to stop the recording. Pause the recording. Okay, stop.